Hello everyone, this is the first lecture for NV2433 Primary Clinical Methods 1. Our topic today is about emmetropia and visual acuity. Based on this diagram, in human eye we can divide into two, which is emmetropia and ametropia. Emmetropia can be classified as refractive emmetropia, axial emmetropia, and also combination of the refractive and also axial emmetropia. The type of emmetropia can be myopia, hyperopia, and also astigmatism. What is the emmetropia and also emmetropia? Emmetropia is a state in which the eye is relaxed and focused on an object more than 6 meters away. The light rays coming from the object are essentially parallel, and the rays are focused on the retina. Emmetropia is an abnormal refractive condition such as myopia, hyperopia, or astigmatism of the eye in which image fail to focus on the retina. The classification of emmetropia, as I mentioned, can be divided into three. The first one is refractive emmetropia, which is referring to incorrect power of the cornea and or the crystalline lens. You have learned in the anatomy of ocular, which is you should know what is the refractive power that contribute by the cornea and also the crystalline lens to the whole structure of the human eye. For the axial emmetropia, is referring to incorrect axial length of the eyeball. The normal axial length of the eyeball is approximately about 24 mm. Any axial length less or more than that is abnormal. And for the third one is combined emmetropia, which is a combination of both refractive and also axial emmetropia. Type of emmetropia. As I mentioned, we have three types. This is myopia, hyperopia, and also astigmatism. The myopia, we can divide it into simple or without astig, or with astigmatism. Same goes with the hyperopia. Either can be simple or without astigmatism, or can be with astigmatism. And the third one of the type of emmetropia is astigmatism. If you refer back to the first diagram, we have another condition we call it as a presbyopia, which is an age-related condition. The presbyopia is a visual condition which becomes apparent especially in middle age and in which loss of elasticity of the lens of the eye cause defective accommodation and inability to focus sharply for near vision. And the presbyopia can be with emmetropia and also can be with emmetropia. Ocular development. This is a revision only. The eye growth is most rapidly during the first 2 years of life. The power of the eye's refracting components adjust to compensate for this growth. These may be programmed genetically or influenced by visually via a feedback loop. And this process is called emmetropization. Emmetropization is the process of reduction in magnitude and variance of refractive error between birth and 6 years of age. What happens is there is changes of both spherical and astigmatic. There is increase of axial length and it's compensated for by cornea and lens curvature. This is very important because we require a clear retina image. For you to understand about the emmetropization, the theory you can read about the animal model and also infant myopia. Refractive status and aging. Based on this diagram, what we can see is generally trend across population begin life with hyperopic. That means we start with the hyperopic eye, then move towards emmetropia and to myopic eye. Later, we can have back the hyperopic. When you reach 80 years old, then become less hyperopic. This is due to changes in the crystalline lens, alteration in the refractive index, resulting in myopic shift. However, these trends are for a population and do not necessarily apply to individual cases within that population. Myopia is the most common refractive error of the eye, and it has become more prevalent in recent years. If you refer to this diagram, what happened in myopia is parallel incident line is brought focus in front of the retina rather on the retina. The myopia, also known as a nearsightedness. The symptom and sign of the myopia can be distant object appear blurry, near object appear clear. Other signs and symptoms of myopia include squinting, eye strain, and also headache. Sometimes feeling fatigue when driving or playing sport also can be a symptom of uncorrected nearsightedness. The myopia can be corrected by a concave lens. What is the cause of the myopia? Myopia occurs when the eyeball is too long relative to the focusing power of the cornea and lens of the eye. This causes light rays to focus at a point in front of the retina rather than directly on its surface. Myopia also can be caused by the cornea and or lens being too steep for the length of the eyeball. And in some cases, myopia is due to a combination of these two factors. Other causes can be because of the altered refractive index of crystalline lens because of the cataract and glucose hydration, and also can cause by side effect of the ocular pharmaceutical such as when you are using pilocarpine. Signs and symptoms of myopia. I have mentioned this thing before, and the sign of the myopia can be reduced distant visual acuity but normal near visual acuity. The symptom can be constant distant blur, squinting, and also short working distance. Based on Bennett and Rabbit 1984, we can estimate the refractive error of the myopia based on the visual acuity. This table shows that the refractive error for the myopia based on the level of the visual acuity. However, remember, this is only estimation for the refractive error. You still need to do the refractive assessment, which is retinoscopy and also subjective fraction to identify the actual of the refractive error. Hyperopia is a common vision problem affecting about a fourth of the population. People with hyperopia can see distant objects very well, but have difficulty focusing on objects that are up close. The condition is sometimes referred to as hypermetropia rather than hyperopia. If you're referring to this diagram, what happens in hyperopia is parallel incident light is brought focus behind the retina rather on the retina itself. The hyperopia also can be called as a far-sightedness. What happens in hyperopia is the near object appear blurry, distant object usually appear clear. And the hyperopia can be corrected by a concave lens. What is the cause of the hyperopia or hypermetropia? As I mentioned, this vision problem occurs when light rays entering the eye focus behind the retina rather than directly on it. This problem can caused by the axial, which is shortened eyeball, or because of the refractive, which is flat cornea or crystalline lens. Other causes of the hyperopia can be because of the posteriorly located crystalline lens or aphakia. It also can caused by the side effect of the ocular pharmaceutical, which is using the atropine. It also can caused by the mass lesion, which is orbital mass lesion, or displacing retina forward, or we can call it as a central serous choroidopathy. Hyperopia and accommodation. As I mentioned before, hyperopia occurs when light rays entering the eye focus behind the retina. However, some of the cases, because of the accommodation factor, even though they have hyperopia problem, the accommodation focus the parallel incident light onto the retina. This normally happens in young patients. In hyperopia, it can be latent or manifest. As I mentioned before, some of the hyperopia is related to the accommodation, and latent hyperopia is really related with the accommodation factor. The latent hyperopia is the amount of hyperopia which can be compensated for by accommodation. And we only can reveal the latent hyperopia by a psychoplegic refraction. You will learn the psychoplegic refraction in the next semester. For the manifest hyperopia, the amount of hyperopia which cannot be compensated for by accommodation. The MOS plus correction accepted without blurring the vision. What is the sign and symptom of the hyperopia? The sign of the hyperopia can be reducing in amplitude of accommodation, reduced near visual acuity. However, usually the distant visual acuity is normal. How about the symptom? Patient can have astigmatism and headache, blur and near, and often have long working distance, which is contradict with the myopia problem. Again, based on the Bennett and Raybert's 1984, this is estimation of the refractive error of the hyperopia. This table shows that the estimation of the refractive error of the hyperopia based on the level of the visual acuity. However, as I mentioned in the myopia slide, this is only estimation of the refractive error. We still need to do the full assessment of the refractive error, such as retinoscopy and also subjective refraction. Astigmatism. Based on the diagram, the astigmatism is a refractive condition that is the result of two principal meridians of the eye having different refractive power. It is common vision condition that cause blurred vision. It occurs when the cornea is irregular shape or sometimes because of the curvature of the lens inside the eye. This figure shows that two types of the astigmatism at different axes. One is at the 90 degree and another one will be 180. When the axis at the 180, that means the blur principle will be at the 180 and the clear principle will be 90 degree. And it's contradict with the when axis at 90 degree, the blur principle will be at 90 degree and the clear principle will be 180 degree. What is the cause of the astigmatism? As I mentioned, it can cause by the cornea and also the lens. If because of the cornea, it probably because of the surface of the cornea, which is asymmetric cornea, meridional difference in refractive index, and also varying refractive index in the cornea. If because of the lenticular lens, it might be because of the asymmetric crystalline lens on the surface, asymmetric lens layer, tilted crystalline lens, and also varying refractive index. Other causes of the astigmatism, it can be because of the posterior retina may be asymmetric, which is tilted or descented, and also because of the lesion of the eye. The classification of the astigmatism. We can classify the astigmatism in 5 categories, which is simple myopic astigmatism, simple hyperopic astigmatism, compound myopic astigmatism, compound hyperopic astigmatism, and the last one will be mixed astigmatism. Please go and find out what is the definition of this classification, and you also should know how to draw the diagram of each classification. In astigmatism, we have regular and also irregular astigmatism. Regular astigmatism is referring to two principal meridians that are perpendicular or 90 degrees to each other. For example, if one principal of meridian at 150, then another meridian will be at 90 degrees. For irregular astigmatism, is referring to the principal meridians that are not perpendicular. There might be have more than two principal meridians, or sometimes there is no principal meridians at all. Example case that we can refer to the irregular astigmatism is keratoconus. This is axis notation for the astigmatism for the right and also for the left eye. This is very important in prescribing the astigmatism to your patient to know where is the axis of the astigmatism. In regular astigmatism, we have 3 types of astigmatism, which is with the rules astigmatism, against the rules astigmatism, and also we have oblique astigmatism. Please find out what is the definition of the with the rule, against the rule, and oblique astigmatism. For your information, astigmatism normally change with the age. For example, infant patients normally have against the rules astigmatism. However, when they grow, the against the rules astigmatism will slowly change to the oblique of with the rule astigmatism. For the adult, normally the astigmatism is with the rule astigmatism. And when they go older, then the with the rule astigmatism will change slowly to the oblique or against the rule astigmatism. What is the sign and symptoms of the astigmatism? Sign of the astigmatism will be reduced distant and near visual acuity. The symptom of the astigmatism can be constant blur distant and near, squinting. Patient might have astigmatism and headache, and also difficulty in adapting to spectacle RX changes. Again, based on the Burnett and Rabbit 1984, we can estimate the refractive error of the astigmatism. This table shows that the estimation of the refractive error of the astigmatism based on the level of the visual acuity. The fourth figure shows that the different type of the refractive error at the same size of the pupil, which is 4 mm. The first figure shows that a normal visual acuity. The second figure shows that the defocus with 0.355 diopter. If you look at the third one, is the vertical blur at 0.5 diopter, and we also have a horizontal blur at 0.5 diopter. So you can see the difference between vertical and also horizontal, and also if you have problem with defocus. This figure shows that the different type of the astigmatism. As I mentioned before, we have vertical astigmatism, horizontal astigmatism, and also we have oblique. So it depends where is the axis of the astigmatism. So this figure shows the difference, how the patient see if they have astigmatism problem. Presbyopia is the normal loss of near focusing ability that occur with age. Most people begin to notice the effect of presbyopia sometime after age 40, when they start having trouble seeing small print clearly, including text message on their phone. This is a normal physiological process and can be corrected by plus lens for near. This happens also because of the reducing accommodation due to the aging. Before we proceed to the visual acuity test, you need to know about the vision. This is only a revision from the previous semester. You have learned everything in the last semester. Vision is a process by which an organism sees and includes all stages of seeing from physical stimulus reaching the eye to the mental perception. What you need to know is the eye needs to form an image. From the image, need to be converted to a neural signal and sent to the brain. From the brain, need to interpret and process the image. You need to know all the process of the vision. You also need to know about the visual performance, which is related to the visual acuity test. The aspect that you need to know about the visual performance will be light perception, object discrimination, object recognition, and also object detail resolution. You have learned the visual performance in the optic visual. Please refer your previous lecture. In light perception of the visual performance, crudest is a crudest form of vision and may or may not accompany by an ability to localize the direction of the light source. Object discrimination is referring to the ability to distinguish an object from its background or surrounding. Requires detecting the presence of an object but does not require its identification. Object recognition is a form of vision which is ability to identify the object. And we measure clinically by asking patients to read letters on a letter chart, which is the visual acuity. Object details resolution, which is referring to the ability to resolve detail, and normally refer to visual acuity with the traditional letter chart with a resolution task. What is the visual acuity? A measure of the limit of high spatial frequency resolution of the visual system. And usually, we measure at the high contrast. Why we need to measure the visual acuity? One of the reasons is because of the legal, which is some of the condition they need to have the visual acuity assessment. And other than that is because of the refractive, which is the indication for the RX or RX changes. Sometimes we can use the visual acuity finding to explain the symptom to the patient. It also can be used for an aid in subjective reflection and also for comparison with any new RX of the patient. The reason why we are measuring the visual acuity also because for the assessment of visual function. The visual acuity can tell us some of the any age-related changes, also in determining the needs for intervention, and the last one might be because of the defining low vision and blind. In visual acuity, we have a few methods for testing. The first one will be minimum detachable threshold, is referring to visual discrimination. Minimum visible misalignment, which is referring to vernier acuity. We also have minimum angle of resolution, which is we measure use with letter chart acuity 1 minute of art. And we also have minimum recognizable threshold, which is the smallest object can be identified by the patient. In visual acuity assessment, normally we use the Snellen fraction, which is introduced by 1962. How to measure the VA or how to record the VA is VA equals to testing distance in meter over the distance at which letter in the baseline subtend 5 minutes of art. Okay, this is Snellen fraction. For example, VA 6/6, that means the testing is 6 meter and patient able to read letter that subtend 5 minutes of art at 6 meter, and this is considered as a normal vision. How about 6/12? When VA is 6/12, the test distance is at 6 meter, but patient only able to read letter that subtend 5 minutes of art at 12 meter, which is larger letter, and this vision is considered is abnormal. Snellen acuity. Normally, Snellen letters are constructed from a 5x5 matrix. Some letters cannot be derived from such array. Such letters require a compromise and are not fully compliant. The unit of the matrix substance is 1 minute of art. Large letters require multiple units, and letters may be from a serif or sans serif font family. Minimum angle of resolution. In the Snellen unit, the smaller unit of a Snellen letter is 1/5, which is the size of the whole letter. However, the acuity may be expressed as this unit, which is minimum angle of resolution or MHAR. It is abbreviated as MHAR. MHAR units are minutes of art. MHAR is calculated by taking the inverse of acuity expressed as Snellen fraction. For example, 6/6 equivalents to 1.0 and 6/12 equivalents to 2.0. Please go and find out how to calculate from the Snellen to the MHAR. You also need to know, or you also can find it, the converter table from Snellen to the MHAR unit. Logma is the logarithm of the MHAR and is the basic of some letters chart. We have two type of chart in Logma, which is Bailey Lobby and also U Waterloo. Please go and find out what kind of the chart that provided by the Bailey Lobby and also Waterloo. What is the factor that affecting VA? The first one will be contrast, which is the lower contrast will reduce the visual acuity. Other factor will be luminance, also one of the factor that will affect the visual acuity. Other factor will be blur, which is emmetropia. It can caused by the either myopia, hyperopia, or astigmatism. Eccentric fixation also can affect the visual acuity, which is the fixation is not on the center of the macula. And the other factor will affect the visual acuity will be the object orientation, either static or moving object. The visual acuity measurement is a standard testing condition for comparable with different visit. If more than one room you are using, it should be identical. If you have different practitioners, it also can be comparable. And VA may become a legal issue, especially for driving license, pension, insurance, claim, and etc. Visual acuity measurement, this is a formula how to calculate the size of the Snellen chart that we use currently. I think you have learned in the optic instrumentation. Please refer your previous lecture to understand this calculation. This is calculation for the size of the letter in the Snellen chart if you are testing at different distance. So it's continuity from the previous slide. So please also refer to the previous lecture, which is optic instrumentation, for the further understanding. And for the illumination, this is standard of the illumination of the Snellen chart, which is at least 130 to 215 lux, assuming 0.8 reflecting factor. Visual acuity testing, the testing condition, we measure the visual acuity with unaided, and we also measure visual acuity with aided, which is with habitual RX or wearing their own spectacle. And the visual acuity we measure monocular and also binocular. And for your info, VA or visual acuity will be better due to with the binocular assessment due to binocular summation in the visual cortex. And if binocular result is worse than the monocular, there might be a binocular vision problem with that patient. And the visual acuity we measure too, which is at distance 6 meter and also near at 40 centimeter or 33 centimeter. So measuring the distance VA, recommended test, which is a Snellen chart at 6 meter. Either it can be projected, printed with frontal illumination or internally illuminated. Position, which is patient seated with an obstruct view of the letter chart, and examiner seated to the side of and facing the patient. For the measuring of the visual acuity, we are follow the standard of the British Standard 4274 for visual acuity test, which is the internally illuminated letter chart will be 480 to 600 lux. Internally illuminated luminance, which is 120 to 150 candela per meter. Letter chart contrast more than 84%, alright? And then projected chart should be calibrated periodically for correct project letter size, lens and slide, keep clean and fungus free. Procedure measuring distant VA. Take the unadded VA first, then followed by added VA. Then make sure that you do the right eye first, then follow the left eye, finally both eyes. Instruct the patient to read the smallest line they can and to guess when they are unsure. If the patient cannot see the largest line on the chart, ask the patient to move closer to the chart until they can recognize the letters. Make sure instruct the patient not to squint the eye. These are some of the examples of patient instruction that you can use to your patient and also in your lab. The first one, read the smallest line that you can just make out on the chart. Second one, try to guess any letters you are unsure of. Third, keep looking straight ahead. Fourth, please do not squint. This is how you record your finding. Note the smallest line read with fewer than 2 mistakes. Errors are recorded by appending 1 or 2 minus signs. Additional letters seen on the next line are recorded by appending 1 or 2 plus signs. Note whether a result is for the right eye, or left eye, or both eyes. Make sure that you note whether the result is added or unadded. Pinhole in the visual acuity test. The pinhole is used in the visual acuity test for differentiate between reduced VA due to uncorrected refractive error and reduced VA due to other cause. If the patient have a VA 6/9 or worse, you need to use the pinhole. If the vision is increased or better than before the pinhole test, then the problem is because of the refractive error. However, if the VA is not improved with the pinhole test, that means it's probably because of the pathological problem. The patient hold a pinhole occluder over the eye to be assessed and an occluder over the other eye. The pinhole size is between 1 to 1.5 mm. If smaller size, it will cause diffraction, will begin to reduce the best VA achievable. Small pinhole also reduce the retinal illumination, which can reduce the maximum VA possible. The word pinhole pH is recorded beside the result of the visual acuity. Recording and interpretation. We can record the visual acuity for right eye, RE, left eye is LE, and both eye is BE. For example, vision on the RE, which is 612, that means vision on the right eye is 612. LE 612 minus 2, that means vision on the left eye is 612, and 2 letters are incorrect. And we have counting finger, which is tested at the 50 centimeter, which is patient can count the finger at the 50 centimeter. We also have HM at 50 centimeter, which is patient can see hand movement at 50 centimeter. If the patient cannot see hand movement, we can introduce light from the pen torch. If a patient can see the light, that means it's light perception. If a patient cannot see the light, then we will write down as a NPL, which is no light perception. And if we write down pH 6/24, that means the VA with pinhole is 6/24. Measuring the near VA. Recommended test. The near test chart at 40 or 33 cm. Letter chart can be letter chart, number chart, or paragraph of the test. Position. Patient seated with near chart at 40 cm from their spectacle plane. Examiner seated to the side and facing to the patient. We have a few notation in measuring near visual acuity. One of it is 6-meter notation. Actually, the distance in meters at which the target letter subtends 5 minutes of arcs. The minimum angle of resolution is 1 minute of arc for Snellen letter configured properly. Using this angle substance as a basis, it is possible to present visual acuity at any distance in 6-meter notation. For example, 6/6 equal to 1/1 m equivalent to 0.4 m. The other alternative near VA notation will be point, which is 1 point equivalent to 1/72 of an inch. Used in printed and computer industry, near chart from 4 or 5 point to 48 to 60 point. Some charts use N5 to indicate endpoint print. Serif Roman form are normally used, typically Times Roman, Times New Roman. We also have another one which is Jagger, which is 1954, this is the old system. The smallest letters are very small. Notation is J1 to J14, and the biggest letters are smaller than those in most other systems. The condition in measuring near VA, which is the test cut, luminance should be between 30 and 51 candela per meter, achieved with room light on full and a lamp direct towards the near test cut. Test cut contrast should be more than 84%. Procedure in measuring near VA. As usual, you will measure the near VA with unaided and also followed by aided VA. Measure the right eye first, then the left eye, and finally both eyes. Instruct the patient to read the smallest line that can make out and guess later they are unsure. Again, make sure instruct patient not to squint the eye. This is a near VA equivalence with different notation. From the endpoint, reduced Snellen's endpoint, and also Jagger unit. For practical session for NV2433, please refer to your lab manual. You also can use the textbook that I have introduced in our discussion for introduction, which is textbook by the Carlson and also Grosvenor. Here, I would like to thank you to Prof. Dr. Rokia Umar for sharing this slide presentation. Thank you.